fast forward to the world that we live in today. Medicine is incredibly complex. There are over 10,000 medications in the physician desk reference today. Now, I don't care how smart you are, and we're all smart people here. There's no one person that can keep track of all the potential interactions, all the potential problems that can occur with that type of thing. There are equally 20,000 randomly controlled trials, articles that are published every year. Now, I like to read. Everybody knows that. But even someone like me, if I read 2 hours every night of a medical journal, in a month, I would be 100 years behind in my reading. So the things that I was taught 35 years ago, the world that you grew up in, that made us successful, really don't function anymore because of the tremendous complexity of the world we face. This complexity is huge in making us change the way we look at things. Medicine is also now incredibly effective. Remember back to the case that I told you about where we had very few options to put somebody with chest pain in. Now, when someone comes to the emergency room with chest pain, you have to make a decision. Do I give them a lytic agent? Do they need to have a catheterization? Does it be a stent? Should I be transferring them? Do they need to have this? Do they need to have that? Tremendous number of things that we need to consider. One of the basic premises of me as a human is I have a microcomputer as a frontal lobe, but it's a really lousy microprocessor. And if it gets beyond 4 or 5 different inputs, I have trouble taking those all in. And yet we know that in any one day, in any one situation, in an 8-hour shift in an ICU, there are 240 or more different inputs that I have to take in. How can one person trained as I did successfully do that? You can't. And the third thing is that it's potentially very dangerous. It's likely that it always was dangerous, but it's much more so now because of our potential to do more things, to do more activities, to engage in more treatments that raise risk. And there's also the fact that it's much more transparent. A key concept that I've found to be very useful is the idea of the evolution of development. But I think it's very helpful for us to think about the fact that as we move into this complex world that's exploding with new things and new dynamics and new changes, this has become a very interesting framework for me to sort of work on. And I want to really sort of take us through this a bit. An idea is something, I think this would be valuable, but can it work? I mean, I have a million ideas every day. Just ask anybody who knows this. But an idea by itself doesn't mean that anything's going to change. It's just something that sounds like a good idea. An invention means that, we've got one that works. It may be bulky. It may be inefficient. It may be non-tenable. It may not be very useful in the long term. But by gosh, we've got one that works. My example would be, does anybody remember those old first Betamax recorders that you had to carry over your shoulder that weighed about 55 pounds and had a camera on your shoulder that you carried around? I did. It was an invention. It worked. But the idea then is that an innovation is actually in a situation where this program, it works over and over, that it actually has been demonstrated that it can be done in a duplicated fashion, that it's also scalable, that it can be sent out to a larger population, that it also provides value, and that there is an associated business model that makes it financially viable. So let's take it to a very personal example from the work that we've done within the Institute for Clinical Systems Improvement and the work that we've done with creating a model for delivering depression care in primary care. This is Ed Wagner's chronic care model. How many of you are familiar with Wagner's chronic care model? This is a model that was set up as an idea. It was created in the mid-90s. It was a concept of how we could better manage people with chronic diseases. But it was an idea. Nobody quite knew how to do it. Nobody quite knew how to put it into place. And in fact, it's ironic that while Ed Wagner created this model at Group Health in the mid-90s, it failed so miserably initially that Group Health didn't go back to using it until a year and a half ago, while the rest of the world was using it around the last decade on a regular basis. The impact model in the depression work was a program that was developed by Jürgen Unitzer and Wayne Caton at the University of Washington. It was a randomly controlled trial research project that showed that, by gosh, we can make this collaborative model work in depression. It was done in 8 sites with 1,800 patients over a year with very tightly controlled parameters, required a lot of documentation, had a lot of excessive activity required to support it, had no financial model, but by gosh, it worked. We knew we had one that worked. So the impact model in 2002 was created and shown that we could do it. But it wasn't until 6 years later that ICSI put the Diamond Project forward, which was deliberately said to say, how can we take the idea of Wagner's chronic care model? How do we take the impact model, which is the invention? But if we're going to make this work, if we're going to have that idea, that innovation, where this is something that is scalable, can be duplicated across a large population, demonstrates value, and has an associated business model, it requires a different level of work. And I would suggest to you that the reason I bring this up is that it's not that any one of these is bad, but the mistake that we oftentimes make is we take something that's still at the stage of an idea or an invention and try to drop it into the population, and then when it fails, we blame the concept, not the execution of it being done.